Lydia. Okay, now we're working. Okay, we have about an hour. Did you take the clicker? Or the clicker? Oh, I know how to clicker. Okay. No clicker. So we have about an hour. Is it this thing? Just that? Okay. So we have about an hour. I noticed there are a lot of behavioral health people in the room, so some of this will be a little bit medical, but I think will still be useful and hopefully will be super useful to the providers in the room. So I am both an internist and an addictionologist. I came to this field out of frustration, not feeling like I had the tools to treat patients in an effective way. So a lot of what I've learned has been from clinical practice, so I'll share some of that with you. And I've tried to take many of my experiences with patients trying to go through this process over the last, say, 5 years of tremendous practice change to create actual practical cases and tools that you can say, you know what, I have a patient exactly like that. This is how I would potentially approach that situation. And I've also tried to boil it down to kind of some paradigms and some general principles. So let's get to it. So we are going to do some math today, I have to tell you. We're going to talk about calculating morphine equivalents. We're also going to talk about how you can approach opioids and tapers in a successful way, and we're going to go through several different cases. Okay, so step number one of approaching an opioid taper is that you first make a diagnosis. What, like Lydia was saying, what are you diagnosing? What is the indication for this taper? And that is really probably your most important step because that's going to dictate how you approach the situation after that. So are we dealing with a substance use disorder? It doesn't have to just be opioids. It could be alcohol, stimulants, benzos, anything. So helping define like what's going on here. You may not always be able to make it. It could just be a concern. But if you have concern for a substance use disorder, you need to kind of name that and own it because that's going to determine the safety of your opioid prescription. Diversion is the patient giving these prescriptions to another person, selling them, what have you. It can be very hard to diagnose, but and sometimes you don't have to be a police officer. You don't have to prove that they did it, but you have to have enough sort of suspicion and some indication that they're diverting. I've broken this up into at risk for immediate harms or risk for future harms. So what do I mean when I say immediate harms? I'm talking about the patient who's in the hospital due to an opioid overdose, in the hospital for an aspiration event, recurrently in the hospital for these problems, has a bowel obstruction or has really severe constipation that's not treated, or a patient who is refusing your monitoring. So you cannot actually safely prescribe to them because you cannot safely monitor them. You can't do any of the universal precautions that we know are standard of care to monitor patients. So if they're not doing that, there's a potential for an immediate harm. You're not able to actually safely provide that medicine. This could be also abstaining from marijuana. Yes, I said marijuana, or alcohol. We can talk about that a little bit more. But does your patient refuse to stop drinking 1 drink per night? That could actually be super dangerous for them to continue to do. It interacts with their opioids directly, and so it could potentially not be safe. And it could potentially cause an unintentional overdose. Therapeutic failure of opioids, what do I mean by that? I mean that the patient has been on these medications for, say, a year, 5 years, 15 years, and their pain is still rated 8 out of 10, and they are incredibly sedentary. They are not active in any roles in their life. They are not working. They're receiving disability. I mean, you could continue to create different ways that these medications are not actually helping them improve anything functionally or quality in their life. They report their pain scores really high, and they report their report their quality of life to be extremely low. So generally, 1 out of 10. So really, really poor quality of life. Are they at risk for future harm? So these are the patients who have been maybe doing okay for a while, maybe not, but they're on really high doses. What is high dose? Well, thankfully, the CDC has come out and sort of helped us define what a high dose is. And now I think we can safely sort of all agree in the nation that anywhere from 50 to 90 milligrams of morphine equivalents is high dose. And anything over 90 milligrams of morphine equivalents is really high dose. So go ahead and accept that anything over 90 milligrams of morphine equivalents is high dose. Basically, once CDC published their guidelines. That's the new standard of care. You can all tell me how you have exceptions to this rule and all those sorts of things. I'm going to tell you there are probably very, very rare exceptions to the need for a dose over 90 milligrams of morphine equivalents. If your patient is concomitantly using benzodiazepines, that would also be a risk, yes?
Is there any similar scale?
Any benzos. Any benzos. They should not be on any benzos if they are prescribed opioids. You're saying, what's a safe dose of opioids?
My question is a little different. If the primary issue is benzodiazepines, we're talking about opiates today, but is there any kind of corollary scale?
A much different question and topic. Probably I can't get to in a short blurb, but I think we could say that maybe any benzos are not really safe for long-term or effective, but we can talk later maybe about that. So at risk for future harms, if they're using high dose opioids with or not having misuse, but they're just continuing to take those, are they using benzos concomitantly? Do they have sleep apnea? And so you know that in the future they could potentially have an apneic event. Let's talk a minute about opioid use disorder and the complexity of it. I don't have time to go through this entirely, but I do want to touch on it briefly. And that is basically that diagnosing opioid use disorder in a patient who's prescribed opioids is a very complex task. It's very hard to do. And the reason is because our criteria for diagnosing opioid use disorder is really kind of more meant or geared towards patients who are using illicit opioids, right? Like they've had lots of consequences of their use. They've had to go somewhere to get their heroin, even if it's given to them. They go to someone who is not a physician or a doctor or a nurse practitioner or anything like that. There are certain procurement behaviors that are associated with the activity of illicit drug use, heroin, opioids, what have you. For a patient who's prescribed pain medication, it's much more complex because they didn't have to go to anyone on the street. They came to you as the provider on a monthly basis or every 3 months, and they did what they were supposed to do. They did their urine test. They did their agreement. They did their pill counts. They did all these things that you asked them to do, hopefully with, as prescribed. But anyway, they didn't really have to go out and seek that in any illegal way, right? So they really didn't have the seeking behavior. They didn't necessarily have the withdrawal that you would be associated with not having this continuous supply of opioids prescribed to them. They also have had a lot of neural adaptations that have occurred to them over the period of time that they've been prescribed opioids. So they have this memory of pain and of taking opioids that we have, in a way, continued to help perpetuate. So they know that they can take their medicine every 4 hours as prescribed. Watch that clock. I'm going to take it every 4 hours. My pain's going to happen every 4 hours. It's going to be really bad every 4 hours, but I'm going to take my pain meds, and I'm okay, and I'm safe, because I'm just taking my pain meds as prescribed. So there's this memory of pain. There's this ongoing sort of perpetual adaptation that has occurred. They have these different pain relief seeking memories and things that are in some ways similar to the procurement activity or the ongoing illicit use that a person might have, such as Every time they see a person who uses heroin, every time they see a needle, they think of potentially using heroin. Well, every time somebody who's prescribed opioids sees a pill, they potentially think about pain, they think about the time they took their pills, they think about their clock, what have you. And those adaptations can become difficult to reverse because of all the things that we've been talking about. And in a way, it's very hard for the patient who's developed these adaptations to distinguish drug seeking and pain relief from drug seeking. So the stimulus for ongoing use can actually be pain, not actually drug withdrawal that we would typically think about. So anyway, it's complex. That's a little bit of getting into the nitty-gritty there. I know Rachel is going to talk a little bit more about that, so hopefully if there are any questions that are still ongoing, that'll help determine or help you understand that. Okay, so the other thing the CDC did was they defined a new equivalency conversion table. And this was actually really important because we can define, okay, 90 milligrams of morphine equivalents is a high dose. Well, what does that mean if you're on oxycodone? Or what does it mean if you're on methadone or hydrocodone or whatever? So, as I just said that 90 milligrams is now considered a high dose, now consider this the conversion table that you will use to determine that. Don't look at any other conversion table, just look at this conversion table. It's in the CDC guideline, it's in my slides, you can find it online. So this is it, memorize it, take a picture of it, whatever. And what's really great about this is finally, because this was really frustrating to me, finally they defined what it was for methadone, because for a long time people were like, well, we don't know what it is for methadone, I don't know, just be careful. It's like, well, what does that mean? What does be careful mean? How careful? So this is now the dosing equivalents, and so I have to say, and sort of fall on a sword, that OHSU had allowed a methadone dose of 60 milligrams per day as our high dose. Yikes, that's 600 milligrams of morphine equivalents on this conversion table, so obviously that's got to change. So anyway, take this. This is the new conversion table. So can you find this somewhere online? Yes, you can find it right here, at agencymedicaldirectors.wa.gov through the University of Washington. You can actually download it on your phone, or not download it, but make it a favorites on your phone. So if you're in the office with a patient, you have your phone, you can just stick in their doses, and it'll calculate it for you, and it does it for methadone. So really important site. So now that you've got that on your phone, right, now we're going to do some math. Okay, so take out your pencils, your pens, whatever, your paper, and we're going to go through calculating the morphine equivalents for each of these. So 25 micrograms of fentanyl patch. Tell me how many morphine equivalents that is. Correct, it is 60. So how did I do that if I didn't use my phone? Well, if I didn't use my phone, I used the conversion factor, which told me that I multiplied 25 times 2.4, the conversion factor, and that gives me 60. So why is it not something different? Because it's a patch and it says per hour. How do I know that that's accurate? Because the 25 micrograms is explicitly the way that it is formulated is so you only receive that amount per hour. It's not additive. So just also believe me, some of you may be naysayers, but just believe me that you can just calculate it using the 25. You don't have to do some special multiplication by 24 or division by 24 or anything. Just 25 by 2.4. Yes? tramadol is not on there, you're right. But doses of tramadol over 400 milligrams, which is way less than 90 milligrams of morphine equivalents. So a dose of tramadol above 400 milligrams is no longer effective. So you would never prescribe more than 400 milligrams in a day. So you can kind of be safe if you're anywhere 400 or less on tramadol, that you're not anywhere near 90 milligrams of morphine equivalents. What's the exact conversion? I don't remember off the top of my head. I can get back to you. But it's pretty low. It's somewhere similar to tapentadol. I think it's actually less than tapentadol. I think it's like maybe 0.3, something like that. Don't quote me on that, but it's a weaker mu agonist than tapentadol. Tapentadol is a stronger mu agonist as well as a serotonin agonist. The same with tramadol, except tramadol is a stronger serotonin agonist than mu agonist. Tramadol is still an opioid, though, so I appreciate you asking that question. Okay. All right, so we did that for fentanyl. Now, sorry, questions?
Yes, so is the fentanyl dose based on 3-day dosing or 2-day dosing?
Good question. It's based on 3-day dosing. So if your patient is taking it every 48 hours, they could potentially be receiving a higher dose. So this is based on switching every 72 hours. If your patient's using it every 48 hours, then they are probably receiving a higher dose. Yes?
I was just going to say that on the calculator online that tramadol, you can put it in. So it says 10 is 1 morphine equivalent.
Great.
So it's like 110.
Great. Yes?
Where is buprenorphine?
Buprenorphine, in a way, doesn't apply, and it's controversial. Sources say that buprenorphine to morphine is about a potentially somewhere between 20 to 40 milligram conversion. So 1 milligram of morphine being equivalent to somewhere between 20 to 40 milligrams of buprenorphine. But it's nuanced. It's sort of like methadone in a way. I wouldn't use this calculator in that sense. If your patient is on Suboxone or buprenorphine for pain, it's a different issue. It's high dose, most likely. If they're on it for opioid use disorder, I wouldn't rely on these calculators. We don't have the same dosing limits for opioid use disorder. We're talking about chronic non-cancer pain safe dosing limits. Okay, who's done the next one? Hydromorphone, 2 milligrams every 4 hours, and oxycodone 60 twice a day. So we've got 2 milligrams because they're taking about 6 per day, so that's 12 milligrams total of hydromorphone times 4 conversion factor, giving you 48 milligrams of morphine equivalents. And then you've got your 60 of hydrocodone times 2, giving you 120 total times the 1.5 conversion factor, 180, so a total of 228 milligrams of morphine equivalents. Does that make sense to everybody? Okay, next. So your methadone, 20 milligrams 3 times a day. I gave you the answer earlier, so. Yes, 60 times 8, giving you 480. Did I do that wrong? Sorry, let me go back. Yep, sorry, that's wrong. It should be 600. The conversion factors changed in the time that I last did this slide. So, okay, so that should be, times 10 conversion factor to give you for 600 milligrams of morphine equivalents. So does everybody understand? I mean, you can obviously use the app as one way, or you can look at the conversion tables and do it that way. But it's important to make sure you know sort of the entirety of the potential of the high dose for the patient. Okay, so let's talk about how you approach this table once you've determined once you've determined the diagnosis, and then you've determined the dose. So you're going to discuss the goals of your taper, how and when will you know it's successful. You really want to kind of establish a dose target and a time frame. So if you kind of go into it open-ended, like, we need to taper you, I don't really know how long it'll take, it's kind of up to you how you want to do it, we'll just see how it goes, probably not going to go very well. You do want to try to maintain the current level of analgesia, but know that that will probably not be possible in the short term. We know that opioid withdrawal is painful. It can be experienced as emotional pain and physical pain. And so understand and reassure the patient that although you may have short-term increases of your pain, that will subside. It's important that you let your, say, 85-year-old patient know that she or he may go into opioid withdrawal, and what is that going to look like. It's really disconcerting for someone who has no idea what happens in opioid withdrawal to start feeling really flu-like and not know why that's happening. So make sure they understand that. Make sure they understand that there's going to be this potential increase in pain and how to manage that, how to call you, how to contact you about it. Discuss how to contact you, and then have a plan for when they do contact you of what you're going to do. We're going to talk about that. Make sure you're scheduling follow-ups or check-ins. Have your nurse check in, see how things are going. Make sure you're seeing them back on a monthly basis or every 2-week basis or every week if you're going really quickly, or maybe even more often than that, depending on the situation. And then trying to identify at least one other self-management goal along the way, something that they can do to help support them during this taper. I saw a patient earlier this week. She's on very high doses, about 400 milligrams of morphine equivalent. She's been on monthly reductions of her opioids. She's been doing really well. And she said, you know, I just have this week after I have the taper that I just can't do anything. Everything is just really uncomfortable. I don't know how to spend my time. I spend my time just kind of sitting around, and I start getting bored, and I start thinking about my pain. And we talked about what are some things, enjoyable things she could do during that week to help support her, help her get through that. And she was happy to note that going shopping with her husband might be something she could do, and she was really into that idea, and her husband was sitting there. So it was a kind of a funny moment, too, and we talked about small rewards being important to help support you and help things going along on this taper. Okay, so if this is sort of the money slide. If you want to just stay for this and then you could leave. I tried to put it all on one slide for you in a kind of a practical way. So we're going to go through this and spend a little bit of time on this. So how are we going to approach it? Again, we've decided what the diagnosis is. We've determined what's going on, and that's going to base on how we approach this taper. So number one, biggest problem probably definitely raises, my anxiety in the room, in the patient room. I'm concerned that there's a substance use disorder. Again, doesn't have to just be opioids, can be alcohol, benzos, stimulants, whatever. There's an ongoing addiction. The patient has loss of control of the use of a substance. Their life is potentially in chaos. Lots of things are going on. What am I going to do? How long am I going to taper them? I'm not going to taper them. I'm going to stop their opioids. Why? Research shows they'll have less pain if they stop their opiates? No, probably not, unfortunately. Why did I stop? Why am I not going to continue to prescribe them opioids? It could kill them. Are they safe to walk out of your office with an opioid if they have an opioid use disorder and they inject their pills? No. Do you think they're safe? Okay. And you're the one who's writing the prescription, potentially. They're not safe. Let's all just agree here. They are not safe to walk out of your office if they have an active substance use disorder. They are not safe. They should not be prescribed opioids. The risks of prescribing to them greatly outweigh the small benefit they may be getting from that prescription. So don't do it. You're not going to taper them. What are you going to do? You're going to immediately refer them, or you're going to immediately treat them. If you have something like a buprenorphine waiver, you're going to consider, is Suboxone potentially a safe treatment for this patient? And what level of shared decision-making is going on in this process? Actually, none. There's no shared decision-making going on about whether they are prescribed or not. You're making a decision that the risks outweigh the benefits, so that's not a conversation. You've made a decision. What you can share is, how are we going to help you? How are we going to treat you? What are we going to do next? You need help. How am I going to help you? That's what you're going to share in your conversation. So you're going to offer them this referral. You're going to offer them the treatment. You're going to potentially transition them to medication-assisted treatment or therapy, such as buprenorphine or methadone. If they have an opioid use disorder, you're going to prescribe them a naloxone rescue kit because their potential for overdose, if they have an opioid use disorder, is very, very high. What setting are you going to do that in? You're going to consider doing that in the inpatient setting if they're really unsafe, like a subacute detox center such as Hooper or CODA or something like that. Or, again, if you have a buprenorphine waiver, you're going to potentially offer that to them in the outpatient setting. Okay, moving on. Or is there a question? Yes.
Yeah, quickly. So, at what point as a medical provider are you defining conditions substance use disorder? As a clinical psychologist, I get there a lot sooner than my medical providers do. Like, they're running applications early in the month. You're out of the building in withdrawal. Or they may be taking, they're batching how they're taking it. So I get there and say, they're not taking it as prescribed, and that already is saying to me this is a substance use disorder. Where are you drawing that line?
So you were saying you get there as a behaviorist faster than the provider does. Yeah. We're probably naive and dumb, honestly, when it comes to this. We're not necessarily seeing all those signs. We're not necessarily having the same conversations you're having with the patient. So if you identify it, you need to reach out to your provider, and hopefully your provider is receptive to say, oh, I see now. Because and just having that perspective is really helpful. So when do we see it? We probably don't see it until, honestly, staff come up to us and say, I think this patient has a problem. Or my MA is like, you know what? Every time Joe calls, he sounds intoxicated, and he always calls like 10 days early for his prescription, and he comes in really threatening, and I think something's going on. And that's when I'm like, oh, maybe I should talk to Joe about that. So I think the office staff is probably going to identify that faster than the provider, because when the patient comes in the room, they might be putting on, kind of a airs or whatever to kind of help convince the provider to continue to prescribe. So I think it's important that you're getting that collateral information from your staff. But hopefully the provider is attuned to this, and they might become more attuned by having specific dates on the prescription so they can clearly see the prescription's always early, doing the urine drug testing very regularly, things like that. So I think those are some ways. But I would not be afraid to share this information with your provider and maybe even refer them to this slide set if they are not here today. Okay, so diversion. Again, you do not have to be a police officer or a judge to be able to determine this. You just have to have enough suspicion. I can tell you it is very, very hard to confirm that someone is diverting their opioids. I think there's only maybe one case that I've ever knew for a fact that the person was diverting. What do? Do you taper them? No. They're not taking their opioids. Who knows what they're doing with it? You have no idea what they're actually taking, what they're not taking. So no, you are not tapering them. The degree of shared decision-making about that is none. It is not safe. So you have to decide that this is not safe and you can't taper them. And then really the intervention or the setting which you're applying that intervention depends on their need for treatment. They could be selling their prescriptions in order to, obtain illicit substances, in which case they should be referred to treatment. But so it would involve a conversation to determine what's going on with the patient. Okay, what if they are at risk for immediate large harm? So they either have been harmed already, or you're really concerned they will be harmed in the very near future. What kind of taper length are you talking about? Well, these are people who, maybe your 70-year-old patient who suddenly overdosed unintentionally because of changes in their creatinine level. It might be someone who developed a serious small bowel obstruction and there's no way to get that treated. So, you really have to kind of weigh the severity, and generally we're talking about weeks to months for a taper. This can have some shared decision making, such as talking to the patient about, the provider's leading it, but talking to the patient about, what would you like to taper first? What do you feel like would be the most tolerable? Would you like to taper your long-acting first or your short-acting first? Would you like to do this over a week or 2 weeks or 3 weeks? What do you feel safe doing? And giving them some choice wherever it's safe and possible. You're giving them supportive care. I'm going to show you some slides of what that means. You're making sure they have a naloxone rescue kit if they've had an overdose recently. You are mostly doing this in the outpatient setting, though generally these are not patients who need more intensive treatment, though they could be. Maybe they need a rapid detox and they aren't going to be able to handle that. You could seek an inpatient setting. What if they've had therapeutic failure? Well, they've been on opioids probably a long time, and they've got a pretty intense hold, and those opioids have a pretty intense hold on them. So generally we're talking about months to even 12 months. Could be a year, could be a little bit longer. You can have some shared decision making here. Again, would you like to taper long acting versus short acting first? You're doing a lot of supportive care. You're doing a lot of hand holding. You are doing this in the outpatient setting, and these are people who may eventually not be able to taper, and they may be most appropriate to consider switching to buprenorphine if they're not able to complete their taper. If they're at risk for future smaller harms, this can take years. The patient that I mentioned before, I think we've at least been going a year, and I suspect it's probably going to take potentially like 3 to 4 years to fully taper her. Hopefully maybe not that long, we'll see, but this might take a while. And why do you keep doing it? Well, you keep doing it because they keep engaging, they're working the program, they're getting stronger, they're doing these other things. There's no immediate risk. If she were to develop immediate risk, well, that timeline might change. There again, you can have moderate shared decision making, doing many of the other things. Again, buprenorphine can be helpful. So if you might notice here, we never really get to a high degree of shared decision making. This is never asking the patient, do you want to taper now? No, it's you've decided that this is not safe for them. There's some sort of harm. They need to taper. You've made that decision. The choices that you're giving them are the ones of what you think are safe for them to be able to determine. And the way you can do this is really remaining in that risk-benefit framework. You're not judging the patient. Is the patient good or bad? Does the patient deserve this medication? Should the patient be punished or rewarded? Should I trust the patient? These are not questions that you're asking yourself. The questions you're asking yourself are, do the benefits of the opioid treatment outweigh the untoward effects and risk for this patient or society? So you are judging the opioid treatment just like we judge all other things in medicine, aspirin, insulin, whatever. So you're judging that treatment, not the patient. And you're making a medical decision just like you make every single day with every single patient that you treat. This is a really important tool. Unfortunately, some of these tools are very expensive still, but they're becoming more accessible. This one right here is this auto injector, which is super fancy, but currently costs $3,000, so I wouldn't recommend it unless you get a grant for it. This is the nasal aspirator, which is about $40, I think, and then there's your syringes with the naloxone. Some of the kits people have been making are around that $40 range. Most insurance policies are currently covering. don't forget to prescribe this to your patient. It actually can be a really powerful change agent for the patient. If you're so worried about them that you need to instruct their loved one how to administer this to them if they overdose, they might really understand that you're really concerned about them. This isn't just a theoretical risk. This is, you're on such a high dose of opioids, I need to ask your spouse to come in right now or your daughter to come in right now, and I need to inform them how to administer naloxone to you if you were to stop breathing. That's a really powerful conversation to have with a patient and their loved one. And you'd be surprised how the loved ones are like, what do you mean I have to potentially use this medication on my mom? Yeah, if she overdoses because she's on such a high dose, you might need to use this. So it can be a really powerful tool. Okay, so how are you going to do this if you're doing a gradual taper versus a shorter taper? We're going to talk through that. So gradual tapers, and unfortunately there's no science to tell us how to do this. So a lot of this is by expert opinion. But a gradual taper is typically a 5 to 10% decrease of the original dose, and you're doing that every 5 to 28 days, depending on the indication. Generally, that does not cause profound opioid withdrawal. And then once you're getting to 30% of the original dose, then you're slowing down the taper a bit, and then you're doing 5 to 10% reductions of that remaining dose. And the reason you're doing that once you get to 30% is because if you kept doing that the whole time, you would start to get really, really big dose reductions at the lower doses. So you can slow it down a little bit, again, if it's safe to do. Which one do you taper first? Well, it's kind of dealer's choice. Which one do you want to do? I can tell you that most patients prefer to reduce their extended release first because they don't feel it as much as they feel the short-acting. So I don't think I've ever had a patient who wanted to decrease their short-acting first, but that is something that you could work with the patient on. I think it's important to provide the patient a copy of their taper plan. So you can say, just as you're giving them an opioid agreement, you might say, you know what, we agreed that this taper is going to occur over 6 months. This is what this taper is going to look like, and you can refer them back to that every time that they come in. What does a rapid taper look like? Well, it depends on how rapid it is, but you may be doing daily or every other day reductions. How do you do that? Well, you just get it done. However you need to do it, you just do it in the time frame that you have decided, knowing that that patient is going to have a lot of withdrawal symptoms potentially, and I'm going to show you the different medications you can provide to help them. If you're using a medication to help them taper, you may also, so something like buprenorphine or methadone potentially in a federally qualified clinic might be helpful. But those would be patients who you're, working with an addiction provider. So these are some of the adjunct medications you can use. Typically, we're talking about clonidine, Vistaril, Phenergan or Zofran, hycosamine, ibuprofen, Tylenol. If they are elderly, you would want to reduce your doses potentially, but these are kind of the sort of mainstays of the non-opioid management of opioid withdrawal. And really what you're trying to do is decrease the sympathetic overdrive that's occurring. And so you're really using the clonidine in that sense, and the hydroxyzine. If they don't tolerate any of these, you could also consider using tizanidine. You wouldn't want to use tizanidine and clonidine because they have the same mechanism of action. You don't want to use benzos. That's going to get you in another whole, ball of wax. So try to avoid that unless there's some extenuating circumstance. Some patients are only going to be able to taper with medication-assisted treatment, and it's important that we're offering that to them. So your patients who are on very high doses of methadone, really high doses of morphine equivalents, have been on the medications for a very long time, have a lot of the trauma, mental illness, distress intolerance, all of these things may not be able to taper. Buprenorphine is a really important resource for those patients, and as are the interdisciplinary pain programs, the other active modalities of treatment. Acupuncture can also be quite helpful for these patients. All right, so we're going to get to some cases, and we have about 20 minutes left, so we won't have as much time as I wanted, but I'm going to ask Lydia to come up, and she's going to kind of talk some about some of the behavioral things that might come up. So we're going to try to make this as interactive as we can in this type of setting. So case number 1, this is a patient who has immediate large risk. So it's a 50-year-old man. He's been on opioids for low back pain for 5 years. He's developed very severe constipation that's not amenable to treatments. You decide that the risks outweigh the benefit of him remaining on a relatively low dose of morphine. How are you going to approach this taper? You're going to have to shout out here because anything is right. So just start shouting.
Before introducing the taper, inviting the behavioral health provider in to talk about it with them because it's going to be scary.
Okay, so he might be scared, so kind of setting it up and making sure he's got supports. Absolutely. Excellent. Yes? Yep, so maybe switch to an IR formulation as opposed to an ER formulation. So one thing you could do for this patient is you could convert, just like you said, that extended release to an immediate release formulation and reduce it in small amounts every 2 weeks or something like that. So you're just continually slowing down. I think the idea of switching from the extended release to the immediate release is an important thing. But it would also be the other reason that you want to do that is because at least for immediate release you can break the pills. It's important that in a taper you're making sure the patients understand you cannot break the extended release pill. If you do, you're changing the formulation. So that's another reason why you need to do that change. So this is a way that you could approach it. Again, there's no magic to like what you do, how you do this, but this is some general principles of doing this this way. Okay, what if this person were prescribed fentanyl 75 micrograms every 72 hours? How are you going to taper him then? What are some of your concerns about him being on 75 micrograms of fentanyl? Pretty high dose, yeah. So we're dealing with a lot of opioid we have to get off. I'm sorry, I didn't hear you. Okay, so you could taper the patch. Unfortunately, the lowest amounts that the patch come in are 12 micrograms, which is effectively somewhere around 30 milligrams of morphine equivalent. So that's a pretty high drop. That's the problem with fentanyl, right? Once they're on that patch, oh boy, getting them off that patch, hard. Yep. Once you get them on lower doses, it could be easier. So generally what I find with the patches is that you have to think about switching them to a different opioid that has more doses available, so you're not having as dramatic drops. So this would be somebody you might consider switching to morphine. You could certainly offer the fentanyl the taper with the fentanyl, but in my experience, it's been easier to work with something like morphine. But I think Lydia's point is a good one, is this somebody you're going to, what kind of education are you going to do about this as well? Because this is complicated, too, to switch from fentanyl to morphine. There's some overdose risk there. You've got to be careful about how you convert them, because what we know about opioid conversions is those can be really dangerous, too. So this is probably somebody that you're going to want to be really careful about following up and making sure they've got a Narcan kit available. So one way you could do this is if you're going to switch to morphine, tapering using morphine, extended release 60-60-60, which is about a 50% drop of total MED. And why did I do that? Why did I drop their MED that fast? Safety, but what's the principle behind it? 2 words. Incomplete cross-tolerance, right? So when you're on one opioid and you convert to another, your brain does not know that new opioid, so it actually can be much more sensitized to that new opioid. So you have to account for that difference for cross-tolerance by decreasing by, generally now we're saying 50%. So there are some different online calculators that allow you to do that. And then, unfortunately, the lowest amount of morphine they have is in these 15 milligram increments, so you're going down by 15 milligrams at a time, potentially, until you're done. And this would take a little bit longer because he's on such a high dose. Okay, he has a substance use disorder, so a 50-year-old man prescribed hydromorphone, a lot of it, and fentanyl patch, of course. He's got chronic pancreatitis. You detect alcohol in a routine urine drug screening, and he admits that he has relapsed on alcohol. What do you do? Call Lydia. Okay, so you're going to stop prescribing. So everyone feels comfortable. We're not going to prescribe to this guy. Yeah, so he's got a lot of medical problems. He's on high doses. He's using alcohol. You know, he's at super high risk. So it's something that could potentially be risky. I think one important thing is that you detected this on a urine drug screen. Does everybody know how to do that on a urine drug screen? What test are you going to order to detect?
Check the box ETG.
Yes, so ethylene glycol. Did I say that? Yes. Now, ethyl glucuronide, sorry, I'm having like a brain fart. Ethyl glucuronide is what you're going to want to check, and that will detect alcohol in the system for somewhere between 72 to 96 hours. The urine alcohol level, if you just do that dip, it's only going to be positive for about maybe 12 hours. So in somebody who's got an active, raging, alcohol use disorder, most likely you would detect alcohol, but it's possible you would miss it. So again, you're deciding the risks outweigh the benefit for this patient. You're referring to detoxification from both alcohol and opioids. You're going to stop prescribing immediately, and you may consider buprenorphine as an option if you were able to be alcohol abstinent. Anything you would do differently, Lydia? Great. Another option, he may not go for it, but if he had stable liver function, you could consider naltrexone for him once he's fully detoxed off of opioids and alcohol, or extended release naltrexone as a potential option. There is some data to suggest that naltrexone at very low doses actually may be effective for pain. It's a hard sell for people who have pain, but I have had a few patients agree to do it. Yeah, you could do, so what I consider antabuse, you could do buprenorphine plus antabuse. This is probably somebody who'd be in like a dispensary-based Suboxone program, so they could have close monitoring and assure that they're taking the antabuse. Same with methadone, that you could refer them to methadone and they could do antabuse and methadone at the same time. Okay, you have a 28-year-old female. She's prescribed opioids for chronic abdominal pain. She lost her opioid prescription for the 3rd time. She's had 2 negative urine drug tests for the opioid that is prescribed and refuses to come in for a pill count. You suspect diversion and you check the PDMP. What are you going to do? So you're going to stop prescribing. Again, you just suspect it. You can't confirm it. It's not like there's this litmus test that tells you whether someone's diverting or not, but it appears that there are safety concerns. So you stop. You're going to evaluate what the safety of this is. So is this somebody that you would potentially prescribe buprenorphine to? Right. Maybe not, because she might be opioid naive, right? Steve says she goes to treatment. So, and she might need to be in more of like a dispensary-based program because of the concerns. But I would also be aware that, this is somebody, there are people who will fake positive opiate. They'll come in just to have like a positive opiate urine and they can say that they have, bad withdrawal, those sorts of things, to get buprenorphine and then divert it. I would say that's a very, very small amount of the population, but you do need to think about that potential risk, particularly in somebody who already has a history of diversion. You just want to be careful about that.
I think another thing to keep in mind is a patient like this, specifically because it's a female, is really figuring out what's happening to those diverted medications. We know that there are lots of women in ICD relationships and intimate partner violence relationships that are diverting the pills to their partners. And so we really want to follow up. Is there any safety concern for you if I stop prescribing these medications? We see that a lot in especially young women.
That's a really good point. Yeah. Yes.
Would you bring in like behavioral health and stuff like the first entry off for opioid prescriptions or first entry to negative substance for opiates? Do you recommend? I mean, we talk to people anytime they have those abuse negatives, we say we have those conversations early on, hopefully so we can have a plan and not get to this point, but so that people have that sort of ability to mix that.
So should you bring in a behaviorist earlier? Absolutely. I mean, or refer to your agreement and be very transparent. Like, and these were not early refills or lost prescriptions that you necessarily refilled early. And it's also another red flag if you don't refill early and they don't call. Because usually if you don't refill early and they're going to be in a lot of distress if they were overtaking, they're usually going to call. If they don't call and they sort of follow the refill for 3 months or something, and then, it happens again, I lost them on a plane, or, they got flushed down the toilet or whatever, then those are some of the, because in my experience, diversion is much more sort of insidious. It's not blatantly obvious, generally, but somebody who's on super high doses and just not necessarily using. Here's a good case of a well-meaning person who wasn't necessarily diverting. She was actually diverting to herself. She was prescribed about 100 milligrams of methadone per day. And she was afraid of an earthquake and all these other things, and so she started just taking some away each month. So her husband found a stash of 300 pills of methadone in her closet, and she decided one day, she got really depressed, she was going to take some of those. So she overdosed and came in, and it all became clear at that point. So it could also just be not following the plan, sort of self-diversion. So, there are lots of different things people will do with their pills. I had a colleague whose patient was getting a monthly prescription for methadone or something like that and never filling it. So actually 2 years into this process, she brought in her provider a stack of prescriptions this high and said, here you go. I wasn't actually filling these ever. I don't know why I kept them, but here you go. I mean, people will do all kinds of crazy stuff with these. So check the PDMP, talk to their partners, those sorts of things. It's just lots of stuff can happen. All right. This is what we call the lost generation or the legacy patient. But I'm calling it therapeutic alliance. This is a person who's on a very high dose of opioids. They've been on them for a very long period of time, but they're actually working with you really well. So it's a 68-year-old woman. She has rheumatoid arthritis. She's prescribed 350 milligrams of morphine equivalents for the past 5 years. She's had no adverse events. She's moderately functional. You've developed a new opioid policy in your clinic, and she really needs to get below 120 milligrams of morphine equivalents to and attempt a taper. She's concerned that she might develop serious harms from her opioids. How are you going to approach this taper? Right, so talking about what actual treatments is she using, can you optimize some of those treatments? Absolutely. That may absolutely help with the taper, for sure. Is this somebody you're going to tell her she has to be off of her opioids in 3 months? Right. She's willing to work with you. She's like, Dr. Weimer, I understand you're concerned about me. I'm really concerned too. Have you seen all these news reports? Oh my gosh, I don't want to be one of those people. Like, I didn't know this would potentially happen to me. Like, what can I do? Like, she wants help. So she is the last patient that you want to alienate and not support to get through a taper. So, but you got to tell her it's going to be potentially hard. So you're going to bring Lydia in. You're going to have her hopefully work with somebody like Lydia who can help support her through this process, because she's there. She wants PT. She wants acupuncture. She wants all these different things. I know it's hard to believe these patients exist, but they do exist. They absolutely do. I have some in my practice, and they're lovely. So you can do this slow taper, 10% per month. It can happen over a year to a safer dose. It may take 2 years. This is not necessarily the person who's going to get off of opioids. She might just get to a safer dose, and she might be totally safe and appropriate at that dose. You could slow down the taper if she starts to have a lot of symptoms. And then, you want to make sure that she's getting appropriate care for her rheumatoid arthritis. Exactly, offering her a DMARD, things like that. How about the alternative to this? This is probably the more common case, unfortunately, the legacy lost generation patient who there is hopelessness, I'm calling it. So there's really not a lot of therapeutic alliance. This patient is not doing well, very sedentary, very high dose. So 63-year-old man, and again, all these cases are real cases. I did not just bring these up out of air. They're real cases. 63-year-old man, history of low back pain, severe depression. He had a work injury in 1982. He can tell you every single thing there is about that injury to a T. He has not worked since and spends most of his day being sedentary. He's been unwilling to engage in additional pain modalities despite multiple offers. He's prescribed oxycodone IR 30 milligrams every 4 hours. You've tried other opioids, but he has not had improvements. He refuses an opioid taper and states he will seek another provider if you start to taper his opioids. What do you do? Call Lydia. Lydia gets involved in all these cases. Right?
Working pretty hard to try to create that alliance, that relationship, like Karen was talking about.
Yeah.
That relationship with him.
Absolutely. Try.
Meds aside for a minute.
Yep.
Say, okay, let's work on us here.
Yep. Try to repair the relationship as much as you can. Maybe have another provider in your office see. Maybe go to the opioid review committee. Despite all that, nope, he's not having it. He is pissed. He doesn't want to taper. You don't get it. He's going to sue you. Things are not good. You've tried. Do you discharge him? Do you have anything to offer him other than just sorry? He doesn't want an antidepressant. But Right, so opioids might be worsening his depression. He might be having subclinical opioid withdrawal that's making him super agitated. He might have some other underlying medical illness. This particular patient did, in fact, actually have a really serious infection that went unrecognized for a while. He ended up getting hospitalized. A lot of things happened. What did we end up doing? Well, we offered him buprenorphine. We offered it to him like 10 times. we kept offering it to him so much, he was like, don't you talk to me about Suboxone. I don't want to hear it. Don't even offer it to me. Just super upset about that. We offered him detox. We offered him additional modalities. We offered him everything there was. We offered him a 1-month rapid taper. He walked away. He got hospitalized. He had some serious medical illnesses. We talked to him inpatient. We offered him behavioral health. We did all of these things. He walked away. He actually went back to his provider and said, just one last time, will you just prescribe me another month? And the provider said, no, I will prescribe you a tapering dose. This poor provider. And he walked away. He said, no, I won't do it. Patient walked away. So any questions, reflections on those cases? Because these are hard, and I think we're out of time, and I want to give some sort of broader question and answer time, the little bit of time we have left. Any questions for me or Lydia? Yeah.
Oh, thank you. On the buprenorphine, there's not enough access to people who prescribe that. How do we deal with that?
There actually, I think, is more access than we understand there is. So there are many dispensary-based programs in the city, at least. So if you're in Portland, I don't really think there's necessarily a huge access issue. There could be an access for Medicare patients, absolutely. What do you do? I think you encourage, if you are a clinic that prescribes opioids, prescription opioids, I think you need to have 1 or 2 providers in your clinic who also prescribe buprenorphine. Like, this is a treatment that primary care can use and utilize, and if we're able to prescribe serious medications that can harm people, I think we're also able to prescribe buprenorphine that can actually save people's lives.
So I'm from Salem, and the providers don't want to do it. They're really reluctant to do it. They don't want to do it. I represent WIVICH, CCO, and so we have the mandate from OHA to taper these folks and offer them buprenorphine or whatever is appropriate. But the access is difficult, and we're not the only region in the state.
So I just want to make a plug in that note that we really, this is one of those moments I think where being a provider and being a little bit of an activist really is, there's some light shined there, because we really need to be working to boost access, and there's a number of things that we can do. We can make it so that people with X numbers can have greater panels of patients, but one of the main things we can do, I think, in Oregon, where nurse practitioners have practice authority, is that we really want nurses and nurse practitioners to be able to do this as well. If nurse practitioners and PAs can prescribe opiates and get people addicted to opiates, then why can't we prescribe medication for treatment of that? And so I think we really need to be pushing at that at a local and a national level to increase access.
I mean, I get it. I get that some providers don't want to do it. I think providers want to pretend that this is not a problem, this is not, or they recognize it's a problem, but they don't necessarily want to deal with the problem that we as a profession have created. And I think there's ownership that we need to take. Like, we actually helped this epidemic occur. So we actually need to help treat the patients who've been affected by this, and this is our job as health professionals. So if you can, I mean, I find it hard to believe that there are not 1 or 2 physicians in each primary care practice who wouldn't be willing to prescribe with assistance. So I get it if you feel kind of like on an island and you don't have any assistance, but there actually is a lot of assistance out there. There's this PCSS MAT mentorship program that's funded by SAMHSA, where you can call a mentor who prescribes buprenorphine and they can tell you how to induct somebody on buprenorphine. OHSU has an addiction medicine consult line, and we're willing to coach people through, once you have your waiver, how to deal with these cases. I mean, there actually is a growing amount of support out there, so I think getting the word out about the resources is important, but also helping providers take some ownership for this issue. I would be incredibly frustrated if I was in your position and providers were not taking any ownership, but I don't know, I guess I have to sit down with some of the medical directors of those programs and try to identify even somebody who has a glimmer of interest. Because I think, it's hard to get started, but once you get started, it's actually one of the more fulfilling things that I do, is to help people get onto buprenorphine and then see their lives improve drastically. It can actually be a huge satisfaction for somebody's practice. And I don't think we see enough of that. I don't think providers have had that experience enough to take that angry patient who is yelling at you and cursing and making a whole bunch of, mess for the whole clinic, see them stop that entirely and actually start being a grandfather and, cutting the grass and doing just normal activities of daily living. I don't think we have that experience enough, but that's actually a really strong possibility for these patients. Yeah.
Could you just speak really briefly about decision making around giving buprenorphine in a primary care setting versus like dispensary based, like when, some thoughts on that?
Sure. I think Rachel is going to get to that a bit, but the person who's maybe more appropriate for dispensary-based would be somebody who has more polysubstance use, drinking alcohol, concomitant benzodiazepines, a higher ASAM criteria, patient placement criteria, people who just need more structure, who would benefit from the more intensive treatment and integration of behavioral health, I think would be most appropriate. But I think a lot of patients can be successfully treated in the outpatient arena, particularly those who use prescription opioids, or it's more of a prescription opioid use disorder. Typically, I find those patients to be a little more stable, have more stable housing, things like that, so you can more successfully do it. And so I think it depends, but those are some criteria. Yeah.
For those who haven't yet, check out Dreamland by Sam Quinones, all about the history of opioid use and abuse.
Mm-hmm. It's a good book, yeah.
So I think we have time for one more question before we break for lunch.
Everyone's ready for lunch.
Or everyone's ready for lunch. Thank you very much, Lydia and Melissa. So we'll break for lunch and start our last session at 1:40.